Good morning, everyone, for our journal club today. And before we start, I'd just like to recognise the people of the Kulin Nation on which I'm meeting on today, but also for those of you to recognise the lands on which you meet with leaders past and present. We no longer need to recognise emerging leaders, and so this is an important year this year. NCAS is all about implementation and innovation, and I really enjoy hearing about what our colleagues are doing out in rural and regional Australia, particularly as they're often less resourced and come up with some more innovative ways to undertake the antimicrobial stewardship. So it's a real pleasure today to have two speakers today. So first up, we've got Geoff from Albury, Wodonga, who's going to be talking about penicillin allergy delabeling. So take it away, Geoff.
Okay, thanks very much. I'll just share my screen. Shout out if this doesn't work, please.
Yep, we'll let you know, Geoff. Yep, perfect. I'm seeing it in presentation mode.
Okay, well, firstly, thanks everyone for having me. It's a real pleasure to be here today to talk to you about what we're doing in Albury. So my name's Geoff Mackay, and I'm an AMS pharmacist at Albury Wodonga Health. And I'm pretty much here today to tell you about how I set up Albury's penicillin allergy delabeling program, and sort of the challenges that were involved in that and what it looks like given it's not sort of funded. So just a bit of a background on Albury Wodonga Health. We're a cross-border regional health service, which makes us a little unique. So Albury's in New South Wales and is primarily acute, and Wodonga is in Victoria, and which is primarily subacute. And we have no EMR, which does make it a little bit difficult to do penicillin challenging because it's quite difficult to actually identify patients with penicillin allergies in the first place. So because we're a paper-based medication chart here at Albury, basically what we have to record patients' allergies is just a tiny little ADR and allergy box on the patient's medication chart, which is obviously a really, really small space and quite inadequate to actually accurately record a patient's allergy and give good details around the nature of that allergy. So we also have an alert sheet. So in theory, all of our patients who have an allergy should also have an alert sheet in their bedside chart, where we can kind of elaborate on that allergy and provide more information. And since I've been doing this, I've probably noticed about 80 or 90% of our patients have one. So they do go, some do get missed, but most patients will have one of these. So this is the basis of how we identify patients if they're allergic from these two documents, the medication chart, allergy box, and the alert sheet. So in terms of specialist staff, we don't really have anyone specifically in the immunology space. We have had a locum immunologist, Joe DeLuca, who I've worked with a little bit with Safer Care Victoria, who's done a few locum shifts, but we have no permanent allergist or immunologist, and we have had no dedicated funding to establish this program. If I had my time again, I wouldn't necessarily do this the same way that I did it 2.5 years ago. But as you'll see in the slides to come, I didn't really plan for this to become what it became. It kind of grew into something much bigger than I imagined. So if I had knew what it was going to be, I definitely would have taken a slightly different path. But at this stage, we still have no dedicated funding for this. In terms of the resources we do have, we have 2 ID consultants, although they primarily work as Gen Med staff specialists. So they actually only have 0.4 FTE in ID. We have a full-time ID registrar who's really integral to the program. And we have 2 AMS pharmacists. And at the moment, it's actually a 0.7 FTE, but that's only changed in about the last 2 months. So basically, we're been 2 pharmacists working at 0.5 FTE, and I'm only working at this time at 0.3 FTE, or just 12 hours a week in AMS. So the funding and the time was quite limited. So why challenge penicillin allergy labels? I'm not going to pretend that I'm an expert on penicillin allergies. I'm not. I've definitely come a long way in the last few years. I would encourage anyone who wants to get really up-to-date, current, and much better explained information to look up Jason Triviano from the Austin Hospital. I think I've been invited to talk today primarily because of him. But what we know is that about 1 in 10 patients who come into hospital will identify as having a penicillin allergy, and only about 1 in 10 of those will actually have that allergy confirmed upon testing. And then even after that, those patients have about an 80% chance to lose that allergy in 10 years, which basically means we're changing a lot of prescribing for what is truly a much smaller patient population than we once believed it to be. And our primary goal in antimicrobial stewardship is to prevent antimicrobial resistance. And if someone has a penicillin allergy, they're far more likely to get restricted antibiotics that we don't want to be using unless we absolutely have to. So you can see on the left there, the outcomes are significantly worse if you have a penicillin allergy. So where a patient has a low risk of a true allergy or a low risk of a severe allergy, there's a definite benefit to challenging those patients' allergy in an inpatient setting. So just a little bit quickly, how did I get into this? So I became the AMS pharmacist at Albury, I think in 2016. And towards the end of 2016 and start of 2017, I was just doing as much CPD as I could to try and improve my competence in the area. And part of that was just listening to Pepper Pen podcasts. And Jason was the very first person interviewed by Pepper Pen podcast. And I just found his explanation of the kind of research and work they were doing at the Austin and Peter Mac hospitals in Melbourne to be really, really interesting, and just could see that there was a real benefit to be had. So that's sort of where the interest sparked. And then my interest was kind of confirmed, I suppose. So this is me and my family. The lady on the left is my nonna, who was actually 88 yesterday. So about 4 years ago in 2019, she was quite unwell. She was in an ICU with sepsis with no source that was clear. And she had an allergy, or a penicillin allergy label, which was just nausea and vomiting to augmentin, which I'm sure you'll know is not really a true allergy. It's a type A adverse drug reaction. And Nonna got vancomycin and ciprofloxacin first line, and she really failed to thrive. And that treatment wasn't changed for 2 days. And she deteriorated and then had to be transferred to a larger ICU in Wodonga hospital nearby. And we were pretty worried about her. It was not looking good. From the beginning, she could have had really any penicillin or any cephalosporin, but both of those drug classes were completely missed because of her nausea and vomiting to augmentin. So she's fine. Yesterday she turned 88, but we nearly lost her. And that, for me, really got me motivated to do something about it locally, because I sort of saw directly the harm that could come from false penicillin allergy labels. So how did I set this up? So just after Nonna's experience in ICU, I decided that I wanted to do something about it. It was March 2021. So by then, I don't want to say COVID had settled down, because that was during Delta, but at least the hospital we were used to COVID, let's put it that way. So I was looking for a new challenge. So I contacted the Austin hospital, basically just wanting to borrow their procedure to see if I could adjust it to make it appropriate for the facility that we have here at Albury, the lack of sort of resources and specialists. And then when I rang the Austin, I kind of expected to hear, yes, you can have our procedure, you're welcome, here it is. Or no, that's inappropriate, do your own work. But what actually happened was basically they caught wind that there was someone in regional Australia that wanted to challenge allergies, and they were really keen to see if the procedure that they'd rolled out at the Austin and Peter Mac hospital could be done in a regional centre. So I got invited to join their research team. So after a bit of work, I became the principal investigator for Wodonga Health for the antibiotic allergy discovery and delabeling program. And it took a fair bit of time to get all of our documents together. About 12 months after I started that process, in March 2022, we challenged our first patient, which was amazing. It was a really good experience. And then October 2022, we officially joined the National Antibiotic Allergy Network, which some of you have probably heard of. So instead of it just being a few hospitals reporting to one database, we now have basically every hospital in Australia that's challenging penicillin allergies reporting to a central database, kind of through the Austin. And it was a moment of immense pride for us to be the second site to be enrolled in that. We kind of bumped ahead of Peter Mac, got our ethics paperwork through a little bit quicker than them, I suppose. And as of today, we've successfully challenged 35 patients and only had one patient react to the challenge dose, which is about the average. So where is this led me? So because of the work that I was doing with Jason and the team of the Austin and Peter Mac, I got invited by Safer Care Victoria to help roll out the Check Again initiative. So if there's any Victorian sites here, you'll have probably heard of this. Basically, Jason is the clinical lead and there's a bunch of us on the expert working group. And I've been working with Safer Care Victoria for about 18 months, training up other regional and metro hospitals to develop a program for themselves. And that's been a really fantastic experience. And just in the last few months, we've had smaller regional sites like Mildura and Ballarat who have started challenging patients. So that's been really rewarding experience. All right, so what is the typical process for challenging a patient? So the most tricky thing is identifying them. So most patients are identified by myself during my AMS rounds. The ID consultants I work with will often flag patients with me that they've picked up on their ID rounds that they would rather change their therapy if they could delabel the patient's penicillin allergy. We do also get referrals from registrars. So we've probably had 3 or 4 patients now that have been delabeled because they've been referred to by registrars, which is really good. It shows that the hospital is starting to become a bit more familiar with our procedure. And I also get a lot of referrals from pharmacists. So I've got here that we assess the allergy label with the NAN app. So that's the National Antibiotic Allergy Network app. That's what we're doing now. For the majority of the procedure, we actually used a different tool, which I'll show you in the next couple of slides. So then if the patient's a low risk for a true allergy or a severe allergy, we basically educate them on their allergy and offer them a challenge. And if they want to go ahead, they sign just a standard medical procedure consent form. And then we also get approval from the admitting team. And then I'll check in with the bedside nurse and the nurse in charge just to see if they've got any questions. Initially, that was most nurses needed a little bit of help, but now that we've done quite a few patients, predominantly medical and surgical, most nurses have actually, at the very least, been aware of an antibiotic allergy challenge happening on the ward if they haven't done one themselves. So I'm getting less and less questions from nurses now, which is good. And then the penicillin is prescribed primarily by the ID registrar, but it can be by the medical registrar, the surgical registrar, and we take baseline OBS for the patient. And then for 90 minutes, we do OBS and a skin check every 30 minutes. So basically 3 other sets of OBS and a skin check. And after 90 minutes, if the patient's had no reaction, we tell them that we no longer consider them to be allergic to penicillin. So I'll then do a post-challenge review of the patient, which basically just involves giving them some paperwork explaining what's happened and saying congratulations. I'll show you that piece of paper in the next few slides as well. And then I do a primary care follow-up, which is basically just contacting the patient's GP and community pharmacy and telling them that the patient isn't allergic to penicillin. Because we're a paper-based system, the more people we tell that the patient isn't allergic, the more likely that that patient will actually receive penicillin when they need it. So before we used the app that came with the National Antibiotic Allergy Network, we were using the Antibiotic Allergy Assessment Tool. Now this assessment tool and the NAN app, they use slightly different questionnaires, but effectively at the end of the questions, you get to the same point, which is the patient's allergy is effectively risk stratified. So we ask the patient, what's the name of the antibiotic you're allergic to? What are the details of the reaction? So is it a rash? Is it anaphylaxis? Is it that your mum was allergic and she thought that there was a genetic component to it? How long ago did it occur? And quite importantly, how long after you had the medication did it occur? How was it managed? Because if you needed to go to hospital for a reaction, that's obviously more severe than if you didn't actually have to do anything to treat the reaction. And then what have you safely tolerated since? And that's quite an important question as well. And then depending on what your answers are, we would put you into one of these boxes. So dermatological, respiratory, hematological, unknown, these sorts of things. Now, there's basically 4 different risks. The white risks are for people who don't actually have allergies. So these are people who say they have things like nausea and vomiting and headaches. So they're very low risk patients. So we can actually delabel them without offering them a challenge with education. But I've been finding that most of the patients want to have a challenge before they actually definitely accept that they're no longer considering themselves allergic to penicillin. So we'll still challenge these patients with a dose of penicillin if they want to. And then the majority of patients we do challenge are the green ones. And there's effectively only 3 kind of cohorts we challenge, which is anyone who had a childhood rash, someone who had a rash but it's been greater than 10 years, and anyone who has an unknown reaction greater than 10 years ago. For all the other reactions, we don't challenge. Just for a bit of information, we don't do it here, but if they come up as a moderate risk or a yellow, it's appropriate to do skin testing on them at a major centre like at the Austin. And then if they are negative to the skin test, they can have an oral challenge. And then generally, if they're a red severe reaction, then they won't be challenged at all. So the NANAP uses the PenFast score, which is a bit more streamlined and quick to do. And there are less questions, but it has been shown to give the same outcomes in terms of risk to the patient. So if a patient scores a 0, a 1, or a 2, we'll challenge them. So our procedure is about 6 or 7 pages long from memory. And if anyone would like it because they're interested in seeing if it's something they can do at their own hospital, I'm quite happy to share all these documents with you. We have a summary of the procedure called the Antibiotic Allergy Inpatient Challenge. And this is effectively a tick and flick document so that as long as all of these things are done, we know that the test is being done in safe conditions and all the necessary paperwork and research responsibilities are taken care of as well. So effectively, we just make sure that the patient is low risk based on the antibiotic allergy assessment tool result, and that they're clinically stable for testing. And that basically just means that they haven't had a fever and that they've been hemodynamically stable for the last 24 hours. And that's just important because if someone does have some observations that kind of go off after the dose, it's a lot easier to interpret those results if they've been stable in the 24 hours preceding. Then we make sure they're not on a corticosteroid at a greater dose of 10 milligrams of PrEP or equivalent, or on an antihistamine, and that's just because we're trying not to mask the reaction. And then basically I won't go through all of them with you, but it's what I was saying before: consent form signed, nurse in charge notified, admitting team notified. And then down the bottom during the post-testing, that's there because now we do have patients that are challenged without my involvement and sometimes even without the ID AMS involvement. And we just need to hear about them so we can follow up with the patient and give them all the paperwork they need and contact their doctor, as well as put the information into our research database. So this is the information I give the patient once they've passed their challenge. Basically, we just have a sticker that goes on the top, and then the form effectively just says, "Hi, congratulations. This is the date, this was the drug you got, and you didn't react to it. We no longer consider you allergic." It does say on rare occasions you may experience a less severe delayed reaction, in 2 or 3 days. If this happens, please let us know. And if you're an inpatient, do this. And if you've been discharged, please do this. And it just gives them the ability to contact us immediately without going through switch. And then we can give them information on what they need to do if they do need to do anything. And this is just a template of what I send to the GP and community pharmacy, but I also follow up and give them a phone call as well. All right, so I thought I'd talk to you about a case. This was actually the second person that I ever challenged. So it was a 56-year-old man. His name's Gavin. Normally we'd de-identify, but you're going to watch a video from him in a minute, and he's given me permission to talk about his case. So Gavin was a 56-year-old man at the time. He had a 2-week history of fever, dyspnea, and lethargy. He'd also had a left arm ataxia and facial paresthesia. And this is all in the context of a recent dental extraction. So he was sent in by his local GP in Corowa to the Corowa Hospital. So Corowa is a town about an hour from Albury. I think its population is probably about 2,000 people, and they've probably got 20 acute beds in their hospital, so quite a small hospital. So he was sent in by his GP after the GP noticed a new heart murmur during an examination. And then he was transferred to the Albury Hospital when Corowa realised how severely unwell he was. So when he arrived in Albury, all 4 of his blood cultures from Corowa flagged positive for either strep or enterococcus. And because of a penicillin allergy, he was put on vancomycin and cefazolin. So his penicillin allergy was a reaction as a child that was unknown. So it was about 50 years ago. And we had a plan for a toe and for an MRI brain. So the suspicion was that he would have endocarditis and that he had septic emboli. So I was introduced to Gavin to see if it would be appropriate to challenge him, and it was. He was definitely a low-risk patient, an unknown reaction 50 years ago. So I gave him amoxicillin 250 milligrams under our protocol, and he had no reaction to that challenge. And then within about an hour, we had him on high-dose ampicillin intravenously, and he had no reaction to that either. So his results were sort of updated in the following hours and days, and his blood culture came back positive for streptomitis, and his toe confirmed that he had mitral valve endocarditis. So he was able to be put on Penicillin 2 grams every 4 hours with synergistic ceftriaxone, and then eventually, about a week later, was transferred to St Vincent's in Melbourne for surgery. Now, he was pretty unwell, Gavin. He was very weak when he came in. When we talked to him, it took probably 2 or 3 visits before we came back where he actually had enough energy to really have the conversation around his allergy. He was just really fatigued. So he had a lot to gain because of this challenge. So with endocarditis, we need to use intravenous antibiotics for weeks and weeks. I think in the end, Gavin had about 4 or 5 weeks of IV antibiotics. So that potentially could have been, 4 or 5 weeks of vancomycin, which is not ideal. Penicillin and ceftriaxone are far less nephrotoxic and far more simple antibiotics to use in infusers. Well, not ceftriaxone, but benpen anyhow. So I followed him up at 3 months post his challenge, and he still had no reaction to challenge, which is really good. Now, part of my work with Safer Care Victoria was that they wanted me to identify a patient that could come with me to Melbourne and speak about their experience with Wodonga Health. So Gavin was actually going to come to Melbourne in March when I did some education down in Melbourne. But good and bad news. The good news is that he actually recovered to the point where he could go back to work, which was really, really good. The bad news meaning he couldn't come to Melbourne. But because of that, he did actually prepare a video with his wife, Michelle, that I thought I'd play for you today. So please share if this doesn't work, guys.
We're both here to tell you, well, Gavin mainly, about his journey down the path to delabeling penicillin. I guess that's what we've heard pretty much of. Changed our lives of not worrying about this penicillin allergy. He's a pretty strong man because he wasn't in a good way when he, did it, and it was the best thing he decided to do.
Once I arrived at Albury Hospital, I had an infection from a tooth extraction, and it wasn't great, apparently. I had all sorts of stuff going on. But once I got in there and I had the infectious disease doctors sort of come in and asked me about my allergy to penicillin. And I really didn't know a lot in terms of Mum sort of said from an early age that I was allergic to it, and that's why I got the red dot next to my name in the medical terms. When they were explaining it to me, that they could sort of tell when that medical jargon was just going straight over my head. So they backed up and put it in layman's terms, which helped a hell of a lot.
Just how serious it was.
So, and then they give me the paperwork to read over and have a good think about it. They give me enough time for myself, on my own, to sort of get through it, read it a couple of times to make sure that I still got it and understood. And the positives, obviously, and the risks that are associated. So you always have that, that little bit of apprehension. And, it's just the way things were then. For me, I felt that if anything was going to happen, it was going to be minor anyway. So, bang, let's do it. Let's go, lowest dose. Well, look, the transition and the delabeling, it's basically saved my life. It's obviously, as I said before, it's sped up what needed to be done before I had surgery anyway. So,
Don't be afraid to ask questions. And
that's the key, because you do, as I said, you get inundated with information and it can be a little bit overbearing and you're trying to process it all, but
it's a positive
in the
thing.
end,
it's been a long journey, but worth it.
The outcome's good. As I said, I'm here, we're chatting, The sun's out up here, so it's grouse.
He's even mowing the lawns.
Yeah.
So,
Just enjoying you guys. You were fantastic. Everybody, trust me, you were brilliant. And thank you for letting us speak. Really, I didn't think of it as a big deal, to be honest. But there you go. Thank you very much.
Goes, I'm all right, and that's what you've done.
Oh,
So
okay,
giving me my husband back, and as I said, a father, and hopefully soon a grandfather.
Okay. So I just wanted to put that there. I actually ran into Gavin, I think about a month ago. He was just walking through the halls of the hospital. I think he had a follow-up. I can't remember what he was here for. I only saw him for about 20 minutes, about 20 seconds, but like he was just so happy to see me and was just so grateful for what he had done through Albury. And I was just really happy to see him because I wanted to thank him because by this stage he'd sort of produced a video and I'd already shown that to Safer Care Victoria. So I wanted to focus on now what support do I have in the organisation moving forward. And down the bottom I've got the gratitude of patients that are delabeled. So obviously there's no sort of support there, but it is very motivating. And honestly, 6 or 7 patients out of 10 that we've delabeled are as grateful as Gavin. Like they're really, really happy to get that extra service that we offer. So currently I still have no dedicated time or funding for it, but I have had a really supportive director of pharmacy and AMS subcommittee who have sort of encouraged me to continue down this path. So my boss has sort of allowed me on days where I have a bit of time on my clinical hours to dedicate to doing some of this work if I had all my clinical work taken care of. I have had very motivated ID registrars, that's really, really important, and enthusiastic pharmacists who have referred lots of patients. So in terms of prioritising patients, it's quite difficult to do because I may only hear that of 3 patients that have penicillin allergies that could be identified and that could be assessed and challenged in any given week. So there's not too many days where I have to strictly prioritise them because I won't necessarily find out about them. In general though, on days where I do get more than 1 patient referred, then I will challenge the patient who has a more pressing need for antibiotics. So thankfully the AMS team actually got some funding, which has literally just started maybe 2 weeks ago. We got an extra 0.2 FTE, which I originally thought was going to be on Tuesday, but it's actually been changed to Thursday. But the ID registrar and I were joking. You've heard of Taco Tuesday, that we would do a challenge Tuesday, which basically meant that we both had far more time. So if anyone referred to us on Tuesday, we'd basically guarantee a challenge. That's now going to have to be challenged Thursday. So what would I do differently? It's become a lot of work, this challenge, not necessarily just challenging patients, but also the research component to it, and then the Safer Care Victoria commitment that I've got as well. So if I had known that all of this was going to happen when I first called the Austin Hospital, I would have brought a few friends along with me. I think it is possible to do this system with no funding and no dedicated time if you have the motivation to do so. But I think it would have been really good if I had set it up with more help, I suppose. So I think having probably 3 people champion it rather than 1 would be really beneficial. So an example of why this is important is there was a patient in the medical ward that they really wanted to challenge towards the end of last year, and it was on a Tuesday, and I don't work at the time. I wasn't working Tuesdays, and they just decided to wait until Wednesday to when I got to work before the patient was challenged, which is sort of silly. The procedure, thankfully now everyone's familiar with it, and that patient would probably just be challenged without any assistance now. But at that time, if I had had a 2nd or 3rd person with me that was sort of had set the program up with me, then that wouldn't have happened. So I think just bringing a few more people along. All right, so that's me done, guys. I'm happy to answer any questions, and if you want any of the documents that I've got for Wodonga Health, I'm really quite happy to share them. If those documents lead to any other sites going down this path and challenging low-risk allergies, I'd be really happy for that to happen. So please feel free to email me if you want me to send you through those documents. And thanks again for having me.
Love that video, Geoff. It's a cracker.
Yeah,
Also to hear grouse like that. You just don't hear that very much these days. So I think there's lots of claps coming up for the screen. Are there any questions from the audience? I do have one though, Geoff, and it comes back to that issue that it's an eternal issue in stewardship, and how much of what we do is often person dependent because of our personalities, and we want to, system change. What would happen if you went away for a few months?
I think it would be okay now. So we're at the stage now where I've got about probably 3 other people that are loosely involved in the program. Probably only one person that's as involved as me, which is the ID registrar. But he has access to the research database. He can add all that information in, and he's as familiar with the program as me. So if I went away, it would continue, and it is set up as just a standard procedure. So if staff search for it on the intranet, it's easy to find. We've probably had 3 or 4 patients who are challenged without any ID AMS help. So there's evidence that it's already sustainable without me. There's just a risk that maybe some of those patients wouldn't get as comprehensive of a paperwork follow-up, and they wouldn't be added to the research database, which is possibly not the biggest deal, but we're getting there, starting to get to the point where I'm less integral, which is the plan.
I've got 2 quick questions because we need to move on to SIM.
Yeah.
But Dan Nguyen, can the results be uploaded onto the patient's e-health record?
That's a really good question. I don't actually know the answer to that.
The GP could put them up though, couldn't he?
I think I don't have a way of doing it at the moment, and this is still, I guess, pretty new.
Yeah.
As a whole. The only thing is that the GP will eventually have a document which will show that it's an allergic, but it's not that direct, I suppose. It's more of an indirect upload. And
thank you. And Rhys Scarborough, this is more of a bigger question, but how can we reduce people getting an allergy label in the first place? I guess that means there needs to be widespread introduction of education to understand how to take an allergy history, right?
Yeah, and I think that's already getting better. So the ETGs have far more information now on allergy labels and what is actually a true allergy and what is just a type A adverse drug reaction. So I do think that's improving. But as this space continues to grow, which it really is, there's loads of sites now signed up to the NAN network. I think that's going to improve with time. But education is key. We need to educate nurses, pharmacists, doctors to actually specifically say, this patient only had a headache, or this patient only had nausea and vomiting. Yeah.
Brilliant, Geoff. We might move across to Sim Galimam, who is a long-standing colleague and supporter of ours. So fantastic to have you on this morning, Sim. And he is a stewardship pharmacist in the Central Coast Local Health District. And this is a really interesting topic. I'm sure there's going to be lots of interest from this, Sim, and that is his work around the use of hard stops for antimicrobial prescribing. So over to you.
Thanks, Karen, and thanks, Geoff, as well. That was a great presentation. I would strongly encourage anyone to get in contact with him. I was in contact with him when I heard he was going to be presenting on this, and now we have a junior pharmacist who's pretty much trying to set up something like what Geoff set up over here based on his work. So yeah, strongly encourage. Let me share my screen.
Perfect.
So thanks for having me, and thanks everyone for dialing in. Yeah, I'm going to be talking about an AMS tool currently being used in the Central Coast called the Antibiotic Hardstop. In terms of what's going to be in the presentation, I'll quickly go over just some stuff about the Central Coast, the current AMS setup that we've got at Gosford and Wyong, very brief discussion of hardstop and antibiotic timeout literature, and then some pre and post hardstop implementation stuff. I'll also be talking about the paper we published on this, mainly looking at results, conclusions, limitations, those kind of things. So the Central Coast is officially part of Metropolitan New South Wales, which was a bit annoying when it came to COVID lockdowns because we had to isolate just like Sydney did. But depending on what part of the Central Coast you're probably more likely to be similar to your neighbouring health district. So up north, very similar to Hunter, New England, but down south, very much similar to North Sydney local health district. In the Central Coast, our acute care hospitals are Gosford and Wyong hospitals, and we do have some subacute facilities at Wyong, at Wodonga and Longjetty. Central Coast is a pretty young age demographic, but like many other local health districts, we're expecting a massive increase in the 70+ age group. And Central Coast is also a very quickly growing population, just in general. I think one of the quickest growing LHDs in New South Wales at the moment. Just wanted to show this one just because it gives a bit of an overview of the kind of specialties that we have at Wyong and Gosford. Because when we rolled out Hardstop, it was a hospital-wide rollout. So it had effects on all of these specialties, and each specialty has their own sort of different kind of complexities and components of the patient's journey. So it does become one of these things that we did have to think about before it was rolled out. In the Central Coast, we have at the moment 4 ID physicians, 2 FTEs worth of AMS pharmacists, with one of them split between 2 other pharmacists. And at the moment, we actually have an ID advanced trainee, which we don't always have. So we're very lucky to have Jess. This is probably the most staff we've been in the last few years, actually, but we generally run at this staffing level, maybe like 1 or 2 FT below. But yeah, everything's always changing, it seems. At the moment, in terms of AMS daily activities, 1 AMS pharmacist will generally review all patients on restricted antimicrobials at Gosford, and the other pharmacist will review everyone on restricted antimicrobials at Wyong. With leave and sickness and competing priorities, it isn't always the case, but it's generally what we try to achieve. We also do twice weekly ICU and whole hospital rounds at Wyong, and twice weekly ICU rounds at Gosford, and then kind of select wards at select wards. Before we get into Hardstop and antibiotic timeouts, I just wanted to kind of confirm the definition, because I feel sometimes, especially when we were starting with this project, that these terms were kind of used interchangeably. So Hardstop in this context is an alert generated by an action that does not permit a user to continue without a resolution, whereas an antibiotic timeout is a provider's reassessment of the continuing need for the choice or for the need of or choice of antibiotics. To simplify things, a Hardstop will see something, in this case antibiotics, to prompt the reviewer to prescribe it, and the prescriber to review it, whereas an antibiotic timeout will prompt the prescriber to review it, but we'll continue the antimicrobial unless that's changed. Looking at literature, there's plenty of literature around Hardstops, especially when it comes to electronic prescribing. Some of the earliest interventions, records I could see were from the mid to late 1990s. So it's been on for a while. More recently, there's been investigations into the use of Hardstops, which force a doctor to address things like a medication problem, or there's one which prevents them from closing a patient's chart until it's resolved. There's Hardstops to force prescribers to pick an indication at the time of prescribing. There's ones for things like HIV screening over in New York, Hardstops for drug indications, interactions, dose checking, some for abnormal blood results. So it's one of these things where it's applicable to many aspects of, especially electronic medication management and patient care, really. Antibiotic timeouts, they also have quite a lot of literature as well. It kind of varies in time from prescribing until timeout, usually between 2 to 5 days after the first dose. Almost all of them show increases in de-escalation, in particular your higher risk broad spectrum antimicrobials. The majority of these studies have been performed in the US, potentially due to the early adoption of electronic prescribing and access to it. But yeah, that's just generally where a lot of it has come from. When it comes to specifically antibiotic Hardstops, there's not as much. There's still a few studies though, and a surprising amount of pediatric studies, which I thought would have been more difficult to get prescriber buy-in and ethical clearance. But yeah, it was a surprising amount. Probably the most notable one was the SCOUT study, which actually showed a reduction in the use of antibiotics by 27%. No difference in safety outcomes in a neonatal ICU in Texas. But yeah, I thought that was quite a good result to have. Another interesting study I found was not prompting a review of antimicrobial use after the initiation of therapy, but kind of before. So it prompted prescribers to ordering C. diff tests in the context of laxative use. This led to a 30% decrease in testing, a 45% decrease in hospital onset C. diff, and no delayed diagnosis of C. diff. I couldn't get access to the full study, but the abstract didn't mention reductions in antimicrobial use specifically. But in general, less C. diff usually means less treatment of C. diff. So yeah, but there was another study I found called, that's probably the most relevant to us, called the ARC study. This was a multi-site randomized controlled trial that implemented an antibiotic review kit in 39 hospitals across the UK. One component of this was a novel prescribing decision aid, which hospitals had the option to include a hard stop or a soft stop function. In the study, 21 of the 39 hospitals adopted the hard stop function, and it works where it would cease the antimicrobial, prompting a review as well at 72 hours from the first dose of antimicrobial therapy. To be honest, their graphs were a little difficult for me to interpret, but they said they found a 4.8% reduction in defined daily doses per acute general admission. And also, funnily enough, they found a decreased risk of death in those hospitals that included the hard stop function, which is what we kind of wanted to see, but didn't think it would be that significant. There's plenty of potential confounders or effect modifiers. For example, hospitals adopting the hard stop might have a bit bigger culture around AMS in general, but yeah, it's difficult to explain. All right, so back to the Central Coast. Before the introduction of hard stop, it's important to kind of recognize that it was also before the introduction of power chart, which is probably the biggest flaw in what we did. Paper charts already had a bit of an innate hard stop in that a large majority of inpatient charts only went for 7 days and they would need to be recharted. Back then, the AMS team used guidance as the means to find out who was on a restricted antimicrobial. And a lot of people who use electronic AMS software know that it relies on the compliance of teams to actually register on the software. Over February and March in 2018, after lots of processes of approval through AMS subcommittee, drug and therapeutics committee, various IT medication safety committees, power chart was rolled out in the Central Coast, including the hard stop function. One thing to be noted is that Central Coast and North Sydney share the same IT system frameworks. So they had power chart rolled out at the same time, but decided to not include the hard stop function, citing safety concerns with patients missing doses, which is fair enough. So this is what it looks like when prescribers go to chart an antimicrobial. For every antimicrobial, excluding infusers, it has a built-in into its order sentences a default of 5-day length of therapy. Once it's selected, you can see it auto-populates the duration to 5 days, but this can be changed at the time of prescribing and actually any time really. And you can change it to have no limit on duration or 1 day in duration. It's just that it auto-populates to it. It's good that at this step, it also prompts teams to register any restricted antimicrobials on guidance with a little link there as well. Which is important to remember when we talk about our specific patient cohort selections in our groups. This is what the charting looks like when it's prescribed. It specifies the duration and the stop date. It should be noted there are currently no automated reminders when a patient's antimicrobials have been hard stopped. We inquire with IT whether this could be built into power charts as a JMO task request or anything really, but didn't make much ground on that. They said it wasn't really feasible. So in terms of who we included in the study, patients had to be 18 years or older, because we didn't want to do anything with pediatrics just yet, who were prescribed a yellow or a red restricted antimicrobial. The dates, we did that just because higher risk, more oversight, and also, interventions in those kind of groups tend to have better downstream effects. The dates we set were between March and May 2017 for the pre-hardstop cohort and March and May 2019 for the post-hardstop cohort. Our primary outcome was to measure the days and lengths of antimicrobial therapy. This was used as it's currently the most accurate measure of antibiotic use according to the Center for Disease Control in the US. And it did kind of fit in well with this study. To explain the difference between the two, if people aren't familiar with it, length of therapy is the number of days a patient is on any antimicrobial therapy, whereas days of therapy takes into account patients on more than one antimicrobial at a time. For example, if someone's on ceftriaxone and doxycycline for 5 days, that would be a length of therapy of 5 days, but a days of therapy of 10 days because they're on 2 different antimicrobials for 5 days each. Patients were randomized from a list of patients generated by Guidance MS. So had they registered restricted antimicrobial and Guidance MS between the March and May dates of the 2 cohorts. Initially, all indications for antimicrobial therapy were included, but when we did the initial stat analysis, we found we didn't have the sample size to give enough power, so we decided to make the inclusion criteria only for patients being treated for community-acquired pneumonia or infective exacerbations of COPD, which were the 2 most common indications for antimicrobials that we had. In the end, we included 100 patients with either CAP or infective COPD exacerbations in both the pre and post hardstop groups who had been prescribed restricted antimicrobials. We collected baseline data, mainly looking to see any sort of confounding or elicit any sort of other patterns that we thought might be interesting. In terms of the primary outcome, we found that there was a non-statistically significant reduction in days of therapy and length of therapy when when stratifying individually by CAP or COPD exacerbations. But when we combined, there was a significant reduction in the mean days of therapy by around 3 days, and reduction in the mean length of therapy by about 2 days after the introduction of hardstop and EMEDs. We just put this down to just underpowering, really. It was also demonstrated when stratified by antimicrobials, ceftriaxone and doxycycline were the most used, mainly because ceftriaxone is the restricted antimicrobial and was included. And there might be other CAP that might have been with Ben10, but it's not restricted, wasn't included. In terms of secondary outcomes of the 100 patients, it was safety. That was the #1 concern when it came to introducing hardstop, really, that people were going to miss out on antimicrobials. So in terms of who missed out, in 100 patients who had the potential to have the hardstop function activated, we had 1 patient miss 24 hours worth of therapy, who was then changed to oral therapy once he was restarted. And 1 patient missed 2 days worth of therapy and then was restarted on the same regimen, but didn't have any documented adverse outcomes or anything really. But still, it's definitely something that we were always considering. We wanted to obviously reduce the chances of patients missing antimicrobials, so looked into contributing factors. Some of the proposed factors include when the hardstop function is activated, such as on weekends, when there's reduced clinical staffing levels. There was also 1 instance where it happened when EMEDs was down and we had to revert back to paper charts. So going to paper charts and back from paper charts created a bit of confusion, I think. There's also times where prescribers are busy or might overlook a hardstop antimicrobial, or even team members not knowing about the hardstop function. We made sure after we saw this, to roll out education and make sure it was included in all the orientations for new clinical staff. As I mentioned before, we tried to get automated electronics tasks generated when either an antimicrobial was or was about to be hard stopped as well, but that made little ground. Probably the main thing that we do now is regular auditing of IMS data to make sure that we're not, this isn't becoming a common thing. So the most recent one, we looked at IMS data between January 2021 and December 2022. There were 190 IMS related to antimicrobials. Of 2 were related to hard stops not being reviewed. The first patient was a 74-year-old female with the MSSA bacteremia. Didn't have any vegetations on TTE or toe, but was very suspicious for prosthetic valve endocarditis. She was on 2 grams of cefazolin since early April 2021. Missed 5 days on day 13 of the course. Sorry, that should be 5 doses. It's 5 doses. 5 days is a bit much. 5 doses on day 13 of the course. Her white blood cells increased during this time, had a fever, had a blood culture taken as well during this time, which turned out to be positive for MSSA, which was unfortunate because she had 3 negative blood cultures since the 16th. She had a fever, and she was restarted on cefazolin by the after-hours JMO with the septic screen. Yeah, this was an unfortunate one. This was reviewed and cited on a harm score of 3. She did happen to pass away 3 months later, but it was from unrelated. Oh, it was semi-related actually. It was complications of a multi-territory stroke and recurrence of the bacteremia after 6 weeks. But to link that to missing out on 5 doses and then being restarted is, yeah, maybe, but it's hard to say. The second patient was a 77-year-old male with an infected subcapsular hepatic abscess, and also a Klebsiella oxytoca bacteremia. The abscess suspect also grew Kleb oxytoca and also a strep neuro. She was on ceftriaxone since late May 2021 and missed a single dose 15 days into her therapy. The notes say he became unwell, but his biochemistry and obs were unchanged, except for a moderate increase in heart rate. It should be noted that some abdominal fluid aspirate grew Enterococcus faecium as well, and he was started on Vanc. So ceftriaxone wouldn't have done anything from that anyway. Yeah, he did pass away a month later, and it was because of his metastatic colorectal cancer and attributed to polymicrobial hepatic abscess. But he was on vancomycin for quite a while. And, yeah, there was not much more that they wanted to do for him. I just wanted to show here the reasonably moderate increase in heart rate and the timing of Vanc administration with recovery. So with the efekium, it's kind of safe to say that the ceftriaxone dose didn't contribute to this. So in the study, we concluded that there was a reduction in respiratory antimicrobial days and length of therapy, which could be reasonably hypothesized to produce a number of positive downstream effects. It's obvious to say this would correlate with the reduction in the unnecessary use of antimicrobials, a potential reduction in antimicrobial resistance rates, C. diff infections in multi-drug resistant organisms, and may lead to reduced admission lengths of stay. In terms of limitations, there's a lot, to be honest. The small sample size made it difficult to elicit significant differences between patient cohorts in days and length of therapy, especially for specific indications. Probably the biggest flaw of it, which is my biggest gripe as well, is that we couldn't discount the influence of EMEDs and all the other functions of EMEDs contributing to these reductions in days and length of therapy. So this was definitely something for the future, hopefully. Another problem is that antimicrobials taken by patients not for respiratory infections, but the patients who they were being treated for CAP or COPD exacerbations were included in the numbers for those antimicrobials, but they're included for all cohorts. So we kind of assumed that would even out. The study didn't look at non-restricted antimicrobials, which have their own overuse considerations. Furthermore, there's always other AMS initiatives going on which might have influenced over-prescribing habits based on what those initiatives were and the staffing levels, so they weren't consistent across the two timeframes. One big positive, but also a big limitation, was the small number of patients who had a missed antimicrobial dose, meaning we weren't truly able to assess the significance of the consequences of patients missing doses. But I'm not unhappy about that. The thing which is probably the biggest killer for this result was that we couldn't confidently attribute this reduction in days and length of therapy to hardstop because EMEDS was introduced at the same time. We needed a larger sample size so we could look into different indications, and it would be nice to confirm a cost-saving benefit as well, but we could have used that specific pharmacy cost data to do that. Also, since AMS generally only looked at restricted antimicrobials, it'd be good to see what's happening outside of the AMS oversight in the non-restricted. And that's all I really had for that one. Does anyone have any questions or anything?
Thanks, Sim. And yeah, just a reminder to everyone to use the Q&A chat feature. Really interesting presentation, Sim. And I guess I'll ask the first question while I'll give others a chance. But with your rollout across your local health district, like what advice would you have for anyone else looking to look at implementing a similar concept at their service?
I would probably say look at the capacity of your AMS team to how many patients they can have daily oversight of. I mean, there's still patients every now and then that we're picking up on rounds where they've been hard stopped, and we have to say, is this been hard stopped intentionally, or this has been accidental, and they'll restart it. Also getting just buy-in from all the key stakeholders, and because there's well, here in the Central Coast, there's so many different specialties and directors of those specialties, and they have their own kind of individual context considerations that you need to be able to talk with them, and I guess have little contingency plans for what would happen in every specific potential scenario, and whether they'd be comfortable or whether they'd have any sort of questions around that or ways they could deal with that. So it's a lot of groundwork to be done before it's rolled out, and everyone to make lots of conversations to have, I guess.
Yeah, so yeah, a lot of stuff was done before this was even implemented, a lot of stakeholder engagement. And then how did you find, was there a bit of initial kickback from some of the clinicians, or like anecdotally, did you find it was relatively well received, the program?
Well, it was actually started before I even came here. So this was all started off in 2000, and I think it was the preparations for the rollout were 2017-ish. And I only came here in 2019. So a lot of this would be from the ID physicians' feedback about how things were going before then. But from what I've heard, yeah, there was a decent amount of feedback, especially in terms of considerations around patient safety and missing doses, and whether we had the resources for the rollout, how we would educate and make sure that it didn't happen. So there was definitely concerns. But yeah, before my time here, unfortunately, or fortunately, who knows.
Oh, good. And Kaz,
Sim,
you've got your
yeah,
feedback?
Sim,
Yeah.
I know that there's been a lot of work in the States around a hard stop for surgical prescribing duration, which is possibly a lower hanging fruit than tackling something like this. Is there any consideration of looking at some other patient populations where you know, where there is clear evidence that they don't need to be continued.
Yeah, that's a good point. Without surgical prophylaxis, it's a yeah. But no, that's a really good point. All the intraoperative stuff is all on paper charts, but as soon as they get out and they get onto the wards, then that's a good point. We found over here it's not too bad. Usually at the most it's for 24 hours. There are some ones where we've been wanting to tackle for a while in terms of introthoracic and cardio surgeries as well. But yeah, that's a very good point.
I guess there's even more evidence now that it should only be even single dose. So we've been relatively lenient with allowing 24 hours, but in actual fact, the evidence supports even single dose. So it's probably a good time for all of us to bandy together. Maybe this is something that these are the sorts of projects I think that would be great to do with a whole lot of people from different areas and think about what it would be and do it as a collaborative. So Court's the right person to contact. As she knows, she's a postdoc looking at surgical prophylaxis interventions. So it'd be great to.
Are you putting my name down for another grant application here, Kaz?
No. It just to get the discussions going around.
I know it is definitely something.
Oh, well,
that I think a lot of
maybe
people are
I am.
interested in.
Maybe I am. Okay, yes. I
I'll
am.
sign up. Yeah, we'll sign up.
But I'm sure there's lots of people online who'd be interested, Court, and yeah. Oh, all right. Look, I'm conscious of the time and apologise. I had to sort of walk into Peter Mac while you're talking, but I was listening, and it's just such an important and interesting area. And congratulations to both our speakers today. As I said, you know, these sorts of efforts are not without significant challenges, and we look forward to hearing a little bit more. I hope you do write them up and publish them, because people do need to understand all the challenges. Implementation science is a big area of interest for NCAS, and we're starting to bring in implementation science more and more to understand how to design a program from the get-go to meet acceptability, feasibility, and always happy to, you know, have any of you contact us for advice if required.
Thanks, Kaz. I say Sim has published, and I'll put the link to that publication with the recording on the website as well. So yeah, thank you very much, everyone.
Great session today.
So next month for July, we have a theme of aged care. For August, it's our veterinary colleagues. And September is looking to be a digital health theme. So everyone stay tuned. Keep an eye out on our NCAS newsletter, on our Twitter feed, and on the website as well. Thanks so much, Geoff and Sim. It was really lovely to have you both here join us today. And I think we had over 40 people online at some stage. So really wonderful to have such great engagement. Everyone enjoy the rest of your days. See ya.
See ya.
See ya.